Mr. Doe is a 64-year-old Hispanic male who presents to the ED with chief complaint of abdominal pain. He has not been in good health recently. He was recently admitted into the hospital 2 weeks ago for a 3-day admission for urinary outlet obstruction secondary to BPH. He was sent home with the Foley catheter and was told to follow up with his urologist, which was 4 days ago, and the Foley catheter was taken out on that visit. His abdominal pain started 3 days ago after the visit and was spontaneous onset and would come and go, but is now continuous. It is a diffuse, dull, non-radiating pain and is only exacerbated with movement and rates the pain an 8 out of 10. He does have more pain in the lower abdomen. Was taking ibuprofen 800 milligrams every 8 hours for pain, but nothing alleviates the pain. Denies nausea, vomiting, or change in appetite. Associated symptoms include constipation for the last 3 days and no urination since the Foley was taken out. The patient came in today because the pain is unbearable and he thought that he was having problems with his prostate again. Stated the abdominal pain was the same pain that he had on the last admission when he had the urinary outlet obstruction. His medical problems include chronic problems with BPH, hypertension, type 2 diabetes with complications of diabetic neuropathy, hyperlipidemia, seasonal allergies, and morbid obesity. He was also in a work accident in 1984 and is currently disabled because of bilateral below-the-knee amputations, which is also his only surgical history. Home medications include loratadine 10 milligrams, Avodar 0.5 milligrams daily, aspirin 881 milligrams daily, Flomax 0.4 milligrams daily, metformin 500 milligrams twice a day, benazepril 10 milligrams daily, gabapentin 300 milligrams TID, amlodipine 5 milligrams daily, Proscar 5 milligrams daily, Vytorin 10 and 40 milligrams daily, and vitamin D3 daily. Denies food or medicational allergies, and denies smoking, drinking, or any recreational drug use. Currently is disabled from the accident and lives at home with his wife. Gets around by wheelchair and is able to do ADLs at home because his house is set up for his disability. Is compliant with medications and states that he is trying to lose weight by using a strict caloric diabetic diet. Diagnostics include a bladder and renal ultrasound from last admission confirming the bladder neck obstruction with an enlarged prostate. So far on this admission, he has a chest x-ray which shows a right lower lobe opacity and EKG of sinus tachycardia 125. Abnormal labs include white blood cell count of 38,000, TSH of 6.93, slightly elevated potassium of 5.3, BUN 20, creatinine of 2, GFR 40, glucose of 240, magnesium 1.5, and a lactate of 4.2. All other blood work unremarkable. The UA was cloudy, yellow urine, dark, with 3 plus protein, white blood cell count of greater than 50,000, 1 plus leukocyte esterase, ABG, pH of 7.3, CO2 of 50, PaO2 of 80, and bicarb of 19 with a base deficit of 7. On review of system, denies fever, chills, weight loss, weakness, fatigue, or night sweats, has been feeling short of breath for the last days. He denies cough, phlegm, asthma, sleep apnea, bronchitis, denies palpitations, chest pain, dyspnea, or edema, does have constipation, and did have the diffuse abdominal pain as described above, but the pain was alleviated after the Foley was put into place. Denies nausea, vomiting, appetite change, or indigestion. Usually does have regular bowel movements. Is passing gas. Has not urinated for the last 3 days. Did have urgency to go, but was unable to pass urine. Denies penile discharge, testicular pain, or masses. When Foley was placed in the ER, there was no documentation of how much urine was passed after the Foley was placed. On exam, the patient is a sick-looking, overweight Hispanic male who is currently on the BiPAP machine, is calm. Nurse says that he has been restless and Ativan has been used. On physical exam, the blood pressure is 90/40, heart rate of 120, the temperature of 39, respirations greater than 20 at 25, and saturations 92% on BiPAP, 12/6, and 50%. Weighs 300 pounds, is 5'2", and the BMI is 54.9. He is alert and oriented times 3, follows command. Skin is pale and diaphoretic. Mucous membranes are dry. His heart rate is sinus tachycardia with a regular rate. No murmurs or JVD or edema. Currently appears comfortable on the pipette machine, is synchronous with the machine. Tidal volumes 4 to 500. Diminished breath sounds on bilateral lobes. Crackles heard on the right lower lobe. Not using accessory muscles but taking shallow breaths. No acute respiratory distress noted. Abdomen rounded, active bowel tones, no pain on palpation, and no masses felt. No scrotal edema or masses. Fully in place with cloudy, dark yellow urine with decreased output of less than 30 an hour. So, my assessment. The patient's chief presenting problem is abdominal pain. This could be due to constipation, bowel obstruction, or ischemia. IBS, MI, gastroenteritis, urinary retention from BPH, or UTI. First, the most likely culprit of the patient's current abdominal pains and overall medical problems was the bladder neck obstruction from the BPH with urinary retention for the past 3 days, which has led to infection and septic shock. This is the top diagnosis because of his recent hospitalization with BPH obstruction and the recent discontinuation of the Foley. The abdominal pain also subsided after the bladder was drained. Patient also had the same abdominal pain with the last admission, which also suggests this differential. Second, a UTI is evident as of the UA. Urine cultures are pending. Third, acute kidney injury, as evidenced by the increased creatinine to 2, with prior creatinine of 1 on the last admission. Fourth, patient has pneumonia, as evidenced by acute hypercapnic respiratory failure on the ABG, and also the chest x-ray confirms a right lower lobe infiltrate on the chest x-ray. Contributing factors could also be possible restrictive lung disease from the morbid obesity. Next, patient does also have a metabolic acidosis as evidenced by bicarb of 19 and lactate of 4.2. This is from the UTI, pneumonia, which has also progressed to another problem, severe sepsis with septic shock, as evidenced by hypotension with unresponsiveness to fluid, leukocytosis, tachypnea, tachycardia, and increased lactate. Blood cultures and urine cultures are pending, but positive UA and the chest x-ray confirms sites of infection. Finally, other differentials include hypothyroidism, which is newly diagnosed from the TSH, constipation per patient history, but this could be secondary to dehydration and infection, uncontrolled type 2 diabetes with hyperglycemia, hyperkalemia, and hypomagnesemia as evidence with labs. So the plan for this patient is admit to the ICU for close hourly monitoring of blood, vital signs, and urine output. Foley was placed in the ED. We'll consult urology and we'll get another renal and bladder ultrasound. Blood and urine cultures are pending. We'll consider consulting nephrology if the acute kidney injury does not resolve with fluid resuscitation. We'll monitor hourly urine output. We'll start on broad-spectrum antibiotics, Levaquin 750 milligrams daily, and Maxipine 2 grams every 12 hours for UTI and pneumonia. We'll give aggressive fluid resuscitation. Patient received 2 liters in ED. We'll give another 2 liters and start the patient on NS at 150. We'll monitor BP urine output and tachycardia for fluid response. We'll consider Levophed if it continues to be unresponsive. We'll continue on BiPAP and keep saturations greater than 92%. We'll get ABG in 2 hours to monitor the respiratory acidosis. We'll also monitor the patient's neurological status and keep the patient NPO, accept meds until the patient is over the respiratory distress. We'll replace magnesium and we'll monitor potassium with a next blood draw in 2 hours, and we'll also monitor the EKG changes. Start on Lovenox for DVT prophylaxis, unable to use SCDs because of the bilateral below-the-knee amputations. We'll start Protonix daily IV for the GI prophylaxis. We'll get KUB for constipation. We'll consult nutritionists after patient stabilizes for weight loss. We'll start on Novolog sliding scale for diabetes and possible insulin drip if unresponsive. We'll start on Synthroid, 0.125 milligrams daily IV for hypothyroidism. We'll get BMP in 2 hours because of the potassium and repeat all labs in the AM plus the chest x-ray and ABG. So key points in summary to this case presentation. First, this patient had a significant history of BPH. Since the abdominal pain went away after the bladder was drained, This would most likely contribute to the abdominal pain and should be the leading diagnosis in the very beginning. Important information that needs to be documented is the post-void amount after the Foley was administered. Second, this patient has severe sepsis, which has developed into septic shock, which is evident by the elevated temperature, tachycardia, tachypnea, and leukocytosis, and the confirmed infection in the urine and lungs. What elevates his to septic shock is the elevated lactate level and hypotension with unresponsiveness to fluid. This warrants quick identification with aggressive fluid resuscitation to keep the SBP greater than 90 and 100 or the mean greater than 65, with possible use of vasopressors. Third, this patient most likely is suffering from a UTI. The most common agent for a UTI is E. coli. Even though complicated UTIs can be caused by E. coli, unusual pathogens such as Pseudomonas and Enterococcus need to be covered since this patient is in septic shock and in the ICU. Levofloxacin and cefepime will not only cover his UTI, but also the pneumonia. These can be escalated or de-escalated if cultures were to come back differently. Fourth and finally, this patient has been complaining of constipation and the abdominal pain, but this constipation is most likely due to dehydration and septic shock. So aggressively treating with laxatives should be pending until the patient is resuscitated. A KOB will help to confirm or not confirm the constipation. But if the pain were to come back, further investigation needs to be warranted.